giving a fluid bolus, a little bit like going to the bar with your friends and buying a round of drinks with a credit card that you tap. It works. When you go to the bar and you tap your credit card for a round of beers, everyone says, thank you, that was great. But if you go back to the bar again and you tap again and you tap again and you tap again, if you do that for 10 nights in a row, one, you might realize that you have a drinking problem, but you might also then realize that at some point you have to pay this off. And so we're essentially collecting this cost of giving IV fluids that accumulates over time.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm Dr. Nick Mark, here as always with my trusty sidekick, the Wong to my Doctor Strange, the Hulk to my Iron Man, the one and only Dr. Cyrus Askin. Cyrus, how you doing, man? You got different digs in the background there.
Yeah, no, I started the podcast in an undisclosed location in a shipping container, then moved on to my recording office, was then ousted by the birth of our second son, and now I'm in my kind of speakeasy come office come parlor. And then today, you can tell the, yes, environment's a little different.
Is that a Motel 6?
Essentially, yeah, it's a home too. I can't say great spot, by the way. Hilton does a good job. But I'm working here in the great state of Wisconsin, doing some nights, seeing some different stuff, and certainly enjoying myself. So forgive me if I fall asleep in the middle of the recording. It's because I just worked last night and I'm not as accustomed to being a night owl as you are, Nick.
Gotcha. Well, I know from polling our listeners that approximately 25% of them would love for us to just talk about the Marvel Cinematic Universe for the next 10 minutes.
Yes.
And approximately 5% of them really, really, really do not want us to chit chat anymore. So
That's right.
I will move this along.
They actually were like vehemently opposed to us chit-chatting at all, which I thought was
exactly
fun.
No, I mean, I think this is a good example of, like, you know, my wife hates it when I say this, but a compromise is both people not getting what they want. So I think we're making all of our listeners unhappy with this compromise where we talk about what the listeners want for 10 minutes.
Okay. Yeah, exactly right.
Anyway, let's move this show along. We've got an amazing topic today, an amazing returning guest. And this is something that we've really been wanting to talk about since the first episode of the show, right? This is a topic that comes up pretty much on every single patient every single day on rounds. Like, if there's one thing that intensivists love to hem and haw about, it's this topic.
That's right. And what is this topic, Nick? Well, the topic we're going to be discussing today is the idea of volume overload, congestion, and how we can assess a patient to decide whether or not giving them additional volume by way of their vein, for example, may be the best option, or if we might be doing more harm than good.
Exactly. So anyway, a returning guest, we'll introduce him in just a second. It's going to be a great episode. There's also some great throwbacks to earlier episodes we did on shock and on diuresis and negative fluid balance. So consider going back and listening to those episodes first. But today we are going to take it in a new direction. I think it's going to be an amazing episode, lots of fun. Without further ado, let's introduce our guest.
Awesome. Thank you, Nick. And thank you, Ross Prager. So Dr. Ross Prager is returning. He was with us on episode 23, where we talked about resuscitative TEE. We're excited to have him back again. You can find him on Twitter, aka X, at Ross_Prager, Prager. Dr. Prager is an intensivist at London Health Sciences Center and an assistant professor in the Department of Medicine at Western University. He completed his medical training at the University of British Columbia, and he's certified in internal medicine and critical care medicine by the Royal College of Physicians and Surgeons of Canada.
Yeah, he's got a lot of things going on. He's doing some really cool research. He was just like flying around in zero gravity, as I recall, doing like zero-G research. But his primary research focuses on using point-of-care ultrasound in assessing critically ill patients, particularly focused on like venous congestion and septic shock. He also does a lot of AI in ultrasound and AI in other areas of medicine. He's an expert on medico-legal implications of ultrasound. He's got some great offerings, like he runs a monthly rounds focused on hemodynamics and congestion. You can find that at hcprounds.com. Yeah, he's also got a startup where they have a AI writing assistant to help researchers reformat when they have to resubmit, www.resub.app. Anyway, lots of cool stuff.
Yeah. For sure. This is a guy that lives on the bleeding edge, and we're excited to bring him back to the show. We've got a lot to talk about. I think without further ado, let's get to it.
All right, Ross, thanks so much for joining us again on Critical Care Time. It's been too long. How are you doing? What's new in your neck of the woods?
Man, thanks so much for having me again. Last time was tons of fun and really looking forward to the discussion. You know what? It's been a great summer, not too much clinical work, so kind of just great weather, lighter clinical load, and just working hard on a bunch of other exciting projects, and really grateful to have the time to come on the show to talk with you guys.
Awesome, man. Well, we're lucky to have you.
Perfect. Well, like I said, there's a lot to talk about here with this huge theme in critical care medicine. It's kind of, critical thing to talk about. No pun intended. Actually, all puns intended. I guess let's just kind of get to the why here. Why is volume assessment so important in today's ICU? And yet, why is volume assessment so important in today's ICU? Yet, it's so hard to reach a consensus on a patient's volume status and then subsequently what to do about it.
The short answer is that volume status, despite it being used every day on rounds and every day in our kind of clinical vocabulary in the hospital, it actually doesn't have a standardized definition. And actually, how you might use volume status might be different than how I might use volume status compared with somebody else. And in practice, people use it really to mean whether or not they think a patient should receive fluids, if they're hypovolemic, or diuretics, overloaded, or do nothing, euvolemic. But there are significant challenges to these definitions. And the reason why is it ties the perceived benefits or risks of diuresis, or giving fluids, with actually an assessment of a true objective physiologic variable. And that's why when you're a medical student or a resident or even a fellow, or I guess consultant for that matter, and you walk around and somebody waves their finger in there and they say, yeah, this patient's euvolemic or hypervolemic, you're like, oh, how did you figure that out? It's always a little bit hand wavy. And it's hand wavy because what exactly is meant by those terms. And so what I really hope to convey in this podcast is that we should stop talking about volume and volume status, but rather focus on true physiologic variables. Things like mean systemic filling pressure, stroke volume and cardiac output, fluid responsiveness, or whether or not somebody will increase their cardiac output in response to a fluid bolus, fluid tolerance, which would be the collective risks of giving somebody IV fluids and trying to quantify those in a semi-quantitative fashion, congestion, which could be left-sided, which is pulmonary edema, or right-sided, like systemic organ congestion, or even things like interstitial edema, which is kind of fluid in the interstitial space that might cause problems at a microcirculatory level. And so what I really want to explore is what are these different terminologies? How does this overlap to the tools that we have to actually assess these?
All right, I love that, and I want to dive deeper and talk about the microcirculation in just a second. But I just want to kind of like emphasize a point you made, which I think is a great one, which is that volume status is less an objective reality and more a justification for a decision you've made, and we should move away from that, right? Like, unfortunately, unlike looking at somebody's labs and saying this person is hyponatremic, volume status is a little more wishy-washy, as you said. But more importantly, not everybody who's hyponatremic needs to get salt. Right.
Yes.
And not everybody who's hypovolemic needs to get fluid. And I think that that's the key thing for our listeners to understand, that volume status is decoupled from volume responsiveness, is decoupled from the clinical decision, should I give this person fluid?
I love what you're saying, Nick and Ross. And I think what we are trying to do, like we often do in medicine, is we try to implement a heuristic, get overly reductionist about what it is we're talking about, completely missing the fact that actually, as it relates to the simple act of giving a patient fluid in their vein or making them, produce more urine, there is a lot of nuance and there is a lot of, discussion to be had that can get lost in the sauce when you compare a patient to like the gas tank in your car.
Now that we've kind of maybe disabused our listeners of one really important fallacy, let's move a little deeper, or a little more microscopic, if you will, and talk about the concept of the microcirculation. So Ross, why don't you walk us through that?
Yeah. We have, in medicine, we have the unique ability to play around with patients' physiologic variables, their heart rate, their stroke volume, blood pressure. We can give fluids, inotropes, vasopressors. And although that these all impact things like MAP and stroke volume, What we really care about is the patient's tissue oxygenation and the tissue perfusion, because organ failure is a tissue level problem. And we make the assumption in medicine that changes that we are going to implement to the macrocirculation, blood pressure, stroke volume, all of those things, will improve microcirculatory health. But that's actually not always true. And there's times that these are coupled, where by improving macrocirculation, we improve microcirculation. But there's times that these are uncoupled, where actually attempts to improve the macrocirculation do not improve the microcirculation. Hemodynamic incoherence.
Or it can even worsen the microcirculation.
Or it could worsen the microcirculation, absolutely. And the reason why I think it's so important to discuss this up front is that right now, Nick, Cyrus, and myself are all fluid responsive. We would all increase our cardiac output in response to fluids. In fact, fluid responsiveness is a normal physiologic state, and fluid unresponsiveness is another term for early heart failure. And so we are all fluid responsive right now. We are all fluid tolerant in that right now you could probably hook us all up to a few liters of IV fluids and we're not going to be significantly harmed by it. Yet none of us need IV fluids and none of us are on an IV fluid drip right now and not getting boluses. And the reason why is our microcirculation is normal. And so you can't get better than normal in medicine. And so that's why I love starting with the microcirculation, because it answers so many questions for us about whether we should get fluids or Lasix or do nothing. Because if a patient has no organ dysfunction and no surrogates of microcirculatory dysfunction, things like cap refill, lactate, urine output, modeling, if all of those are normal, it makes it harder to justify doing a hemodynamic intervention because you can't get more normal than normal. And really, this thinking has come out of a few studies, but one I wanted to highlight in particular, the Andromeda Shock study. And I'm fortunate to be a co-investigator on Andromeda Shock 2, which is kind of the next phase of this randomized controlled trial, where we're looking at patients and phenotyping them based on capillary refill time as a surrogate for microcirculation. And what Andromeda Shock 1 showed was that in patients in septic shock, using cap refill to guide decisions about fluid administration, vasopressors, and inotropes may actually improve mortality for patients with septic shock compared to traditional metrics, because it places the organs and the tissue that we care about at the forefront of why we're doing hemodynamic interventions.
Yeah, and that's also, I think, brilliant, because it's something that is free, essentially, for folks to assess. And a lot of times, I'm also guilty of this. We're often speaking to folks that are practicing in academic centers or private practice in developed countries, but a lot of critical care is occurring in places that are not quite as robust or not quite as well resourced. And so having a tool like cap refill that we can depend upon and then make decisions based on, I think is really important. I think that's great for critical care kind of internationally. And certainly, yeah, Andromeda Shock is a pivotal trial. I'm excited to see kind of the results of the new study you're discussing.
The sequel is going to be good too, I think.
Yeah, exactly. We're super excited for that. I wanted to ask kind of a very basic question, but before I do that, just to make sure that our listeners, aka me, we're totally clear here. When we talk about the microcirculation and the macrocirculation, if you had to define those two terms in a sentence or two, how would you do that?
I would say that the microcirculation is talking about capillary level perfusion to different organ beds.
Perfect.
Not visible through your standard eye, not measurable unless you have things like dark field microscopy or these kind of more advanced tissue perfusion monitoring techniques, but we can rely on surrogates of them, things like cap refill and modeling, that give us a clue into what's happening at a microcirculatory level. And then macrocirculation, I would define as any of the hemodynamic variables that we can easily measure and intervene on. Things like stroke volume, heart rate, MAP, cardiac output, and even markers like venous congestion or high left-sided pressures or high right-sided pressures that are being transmitted backwards and causing organ congestion and organ failure.
Awesome. Okay, great.
I think the original sin here in medicine is that some things are easy to measure and some things aren't. And sometimes we think that the things that are easy to measure, like blood pressure, is important, when really what we care more about is flow. And the things that are hard to measure, like how much oxygen is being delivered to tissues, right? Your VO2 is actually hard to measure. And so it's harder to make that a resuscitation goal.
I totally agree. And even one step further to that is that at a tissue level, it's not just delivery of oxygen, it's where is that oxygen actually being delivered and is it making it to the cellular level? For example, in patients with a microcirculatory dysfunction and septic shock, we know that there's this arteriovenous shunting of blood where some blood is actually being diverted away from capillary beds, and the capillaries actually close off. And in fact, volume overload and peripheral edema contributes to this microcirculatory dysfunction because it pinches off the capillaries and it leads to this AV shunting. So even though if you measure DO2 by looking at the amount of blood flow actually going out, that's actually not the amount of blood flow going to various organ beds. And different organ beds might have relative amounts of shunting and relative amounts of microcirculatory dysfunction. So it just adds a whole other layer of complexity that I think only more recently are we starting to understand.
Right. And only recently are we developing even the research tools to even quantify these things, let alone bedside tools. So we still got some room to develop here, I think.
So, okay, I got it. This sounds really cool. It sounds very experimental. It's super thoughtful. Thanks, Ross. Why don't I just give the patient 500 cc's of fluid and see what happens? I mean, that's much easier for me to do. It costs next to nothing. I'll get to see a response or I won't. And I'm not really, yeah, maybe a couple capillary beds here and there will get volume overloaded, but I'm not really going to do that much damage, am I?
You know what? It's a great question. And the short of it is, if you're just giving one 500 ml fluid bolus, you probably aren't doing that much damage. It's not the end of the world. We all do that. We've all done it before. We all will do it again. The problem comes when that becomes the default mindset by which we approach the sick patient. And I make two comments. The first is, when I think about a bolus of IV fluids, we have to be honest about what it actually is. It's just salt water. When you give salt water to a patient as a bolus, it might increase their mean systemic filling pressure. That mean systemic filling pressure might increase venous return to the heart, which increases cardiac output, and then you might improve your macrocirculatory hemodynamics, which might improve your microcirculation. But as you can tell from that, there's a lot of potential assumptions.
I heard a lot of mites there.
Exactly,
Yes.
exactly. And so I kind of view giving a fluid bolus a little bit like going to the bar with your friends and buying a round of drinks with a credit card that you tap. It works. When you go to the bar and you tap your credit card for a round of beers, everyone says, thank you, that was great. But if you go back to the bar again and you tap again and you tap again and you tap again, if you do that for 10 nights in a row, one, you might realize that you have a drinking problem, but you might also then realize that at some point you have to pay this off. And so we're essentially collecting this cost of giving IV fluids that accumulates over time. And this is kind of the concept of fluid accumulation syndrome or fluid creep, where patients become progressively overloaded and we have to pay it off. But the question is, what's the cost then of overload? We know that for critically ill patients, volume overload is an independent factor for mortality. And I used to always think, well, is this just unmeasured confounding? Sicker patients get more fluids, so like maybe it's just illness of severity. But there's actually more and more support that there's direct mechanisms by which fluid overload causes organ failure. One of them is through venous congestion, which could happen on the left side and manifest as pulmonary edema, or right side, as we're going to talk about, and manifest as organ level congestion. But then it can also impair microcirculatory function and lead to this concept of hemodynamic incoherence, where no matter what hemodynamic interventions we're doing, be that vasopressors, inotropes, or fluids, the microcirculation is just shut down, the capillaries are pinched off, and we can't get the blood to the organs that we care about. And so I don't think a single fluid bolus is the end of the world. We've all given those boluses just empirically. But what I really would advocate for is a thoughtful approach to why we're giving fluids and potentially what other alternatives we have to increase mean systemic filling pressure, for example.
Great thoughtful answer there. I really like it. So I knew that you were a little bit of an IVF nihilist, but I did not realize you were such an IV fluid hater.
I wouldn't say I'm an IV fluid hater. I just want us to think about physiologically what fluids do. The way that IV fluids can benefit patients are, you give a bolus of fluids, it increases mean systemic filling pressure, and that increases cardiac output. There's a lot of assumptions along the way there. For example, we know that about even in the emergency department, early on in septic shock, up to 30% of patients might be fluid unresponsive, but that at the end of 8 hours of resuscitation in septic shock, for example, during Andromeda Shock 1, the RCT, less than 10 or 15% of patients were fluid responsive at that time. In the ICU, only about 30 to 40% of patients are fluid responsive at that time. So there's many patients who have no conceivable benefit of getting IV fluids, yet they're still exposed to potential harm. But even patients who are fluid responsive, you really have to ask yourself, is it fluids that they need or increased mean systemic filling pressure from another mechanism? And so I just want to take a
Mm.
step back and talk a little bit about mean systemic filling pressure, because I think it's so important, but it's not something that we talk about very much. And so if right now, while we're recording this podcast, I go into fatal arrhythmia, I go into VF, you guys don't know my personal address, so you can't even call 911. So I
Actually,
expire
I do.
essentially.
I'm behind you.
Yeah. And so I have a cardiac arrest and I die, and I'm just laying on the floor here. Nobody intervenes. My wife sees it and says, "Thank God." But somebody places an art line in me and measures my pressure maybe 20 minutes later. The pressure in the art line is not zero, despite what we might think. The pressure is actually reflective of two things. It's reflective of the amount of blood I have in my body and the tone on the vasculature. And that generates a thing called the mean systemic filling pressure, which is actually the pressure that drives venous return in our body back into the heart. And this is roughly proportional to your mean systemic filling pressure minus your right atrial pressure drives venous return. And so there's two components to mean systemic filling pressure. The first is the volume, but the second is the tone. Because our volume in our body doesn't only exist in one compartment. There's kind of two conceptual compartments. There's the stressed volume and the unstressed volume. And the unstressed volume is about 70% of our blood volume. And our blood is just sitting in these pooled venous vessels that are really, really high capacitance, kind of low flow vessels. And it's not really actively participating in circulation versus our stress volume is what's actively participating more in circulation. But by giving vasopressors, for example, we can increase the venous tone and recruit some of that unstressed volume into our stress compartment, increasing venous systemic filling pressure, and thus also increasing stroke volume and forward flow and venous return. And so when I hear a patient, for example, with sepsis who's fluid responsive, they might be responsive to fluid, but I always ask, will this patient potentially just be vasopressor responsive? Because if you can give them a vasopressor and recruit unstressed volume into your active circulation and increase cardiac output, you've essentially gotten the same benefit of a fluid bolus, which we know that after an hour, about 80% of it or more will leak out into the interstitium. You've gotten the same benefit as a fluid bolus, but it hasn't cost you anything, because you don't have to pay off the debt of that fluid and you don't have it contributing to volume overload and organ congestion and all these other complications associated with fluids. And so back to your question, am I a fluid hater? I'm not a fluid hater at all. I just want us to really rationalize why we're giving fluids and when we should consider tapping that credit card time and time again versus when we should take a more cautious approach and just recruit kind of unstressed volume with vasopressors, for example.
Excellent. All right. Sorry, I called you a hater. That was a great answer. I want to emphasize two points you made there. One is to what I said earlier about there are things that are easy to measure and things that are hard to measure. Mean systemic pressure is the quintessential hard to measure because you have to be in cardiac arrest to measure it. So that limits our ability to measure it clinically at the bedside, even though that is a key thing. I think the other really important thing that you said there is something that we mentioned back in the episode we did on pressors, right? That we think of vasopressors as vasoconstrictors, but they're also venoconstrictors. One of the most important things that norepinephrine is doing is it's constricting your veins and it's shifting those high capacitance vessels and shifting unstressed to stressed volume, right? And so that's why pressors work even if you're hypovolemic, for example, because you're making up for that by changing capacitance. And I think that's something which is definitely people are undereducated about that.
And I think it also really underscores why the terms hypovolemic and why it's not that useful, because it's not about the volume, it's about where the volume's sitting. So unless you have a patient who's actually bleeding, and those people are objectively hypovolemic, for many of our patients with septic shock, even when they have hyperdynamic biventricular function and a collapsed IVC, they're not actually hypovolemic. They just have the volume in the wrong place. And when we use terms like hypovolemic or euvolemic or hypervolemic, it causes us to cognitively fix on volume when really the issue might be tone, it might be congestion, there might be other things going on.
That's a great point as well, which is that if you think about weight, right? Like if I go into septic shock right now, my weight doesn't change. The total amount of fluid in my body hasn't changed, right? What's changed is where that fluid is and whether it is contributing to effective circulation or not. So that's a great way to put it.
And I think to sort of summarize what I'm hearing, because this has been 25 minutes of, I think, very high level, critically important but dense stuff. So I think to summarize it, the idea of volume status, emphasizing volume, is again reductionist medicine, and I think puts the focus on the wrong element of the patient's presentation. More importantly stated is, you know, does that patient have the means to sort of like augment their cardiac output to therefore support their their end organ function at their current volume level, whatever that volume may be, and then sort of deciding based on some of the tools we're going to discuss and some of the things you alluded to, how best to manage that patient, recognizing this other theme, which is the potential uncoupling in states of pathology between the macrocirculation and the microcirculation, which I think that's a concept that often gets lost, when you're quickly rounding on a patient, really not considering the nuance that you've alluded to, Ross.
Yeah, and maybe I'll just hop in and just say that at this point, people might be thinking like, "Oh, so Ross just goes to rounds and pontificates for hours about all these nebulous variables." I really try not to, because that's such a hateful thing to do and make trainees sit through. And so really, I want to give you my approach, which I apply to every patient in shock for the most part. I start by assessing a surrogate of the microcirculation, like cap refill time, modeling, skin temperature, urine output, lactate, whatever variables, try to get as many of those as you can. I then ask myself, is this patient fluid tolerant? And there's different things that go into that. Are they congested on the left or right side? Are they overloaded from an interstitial edema perspective? Do they have an acute illness that would just make it silly to give them IV fluids? Because again, fluid tolerance is what are the harms? So like if you have a patient with acute decompensated heart failure with pulmonary edema, I don't really need to think about whether they're fluid responsive because they're not fluid tolerant. We would never give these patients fluid. I think about their chronic comorbidities. For example, do they have an EF of 5%? Imagine you see a patient in the emerge with sepsis with an EF of 5%. We're going to be trembling as we give them IV fluids because intuitively we know that the risks associated with those fluids are so high. And other things like end-stage renal disease, pancreatitis, other things that might make a patient less fluid tolerant. And then the last thing, if the patient is microcirculatory dysfunct or has microcirculatory dysfunction, they have fluid tolerance, we could give them fluids. Then I ask myself, all right, is this patient actually fluid responsive? And now I might just empirically give them a fluid bolus and see whether or not their microcirculation, their hemodynamics get better. Or I might try something like a passive leg raise. And that's where we can get into all these different tools that we can use to assess these. But the question of whether we should assess these in the first place comes down to, is this patient having microcirculatory dysfunction? Are they fluid tolerant? And then we need to assess for fluid tolerance and fluid responsiveness through things like VEXUS to assess for venous congestion. And then for things like passive leg raises, pulse pressure variation, serial VTI, etc., which all have pros and cons to the approaches, which we're going to talk about.
That's like a perfect like 30,000 foot overview for like the rest of our conversation there, right? Which is like, who do we even need to go down this algorithm for? Who's got dysfunction? Who's tolerant? Who's responsive? So let's just walk through those. You want to double click on each of those and we'll discuss more?
Yes, it sounds great. And even though I'm technically board certified in internal medicine, don't trust me to look at a neck for a JVP. So the JVP is a really non-invasive bedside quick way of assessing a surrogate of right atrial pressure. You know what, right atrial pressure is good for many things. It is not good to predict fluid responsiveness. So you definitely can't use it like an oil gauge to say fuel up or fuel down. If it's very high, that is suggestive of elevated right atrial pressure that may be associated with venous congestion. Unfortunately, due to differences in anatomy and ultimately just really poor test characteristics from an inter-rater reliability perspective, I don't really use it much in my clinical practice. However, there are some populations where it can be very useful. For example, outpatient pulmonary hypertension patients, tricuspid regurg patients, it might be more useful in those populations.
So what you're saying is that on rounds, you're not there with like the popsicle sticks, at the exact angle, trying to
And the
measure
light and the pen
JVP.
light.
Yeah.
Shining the pen
Somebody
light
else holding the
at
light
angle.
off at an angle. Yeah. This like arcane internal medicine. This is like the hazing ritual of like joining internal medicine, by the way.
Very much so. Very much so. I think if you view volume status as simply an oil gauge up or down, then spending a ton of time to assess the JVP makes a lot of sense. But if you're like us, and we really view this as one very small part of a holistic thing about the microcirculation, fluid tolerance, and fluid responsiveness, it only assesses a fraction of that entire pathway, and it doesn't even do a great job with that. So very quickly, it you're just not going to spend time on it because it's just not worth spending that much effort for such a small piece of the puzzle. So even that alone, I think, really gets rid of its use in modern medicine when you start thinking about that.
Great. Okay, so JVP, yesteryear. What other clinical assessment tools do we have at our disposal?
I mean, assessing for peripheral edema is such an incredibly important thing. If you have edema in your interstitium, you will likely have edema in your organs, for example, your bowels. You might have edema in your lungs. They don't correlate one-to-one because peripheral edema is more right-sided. There's left-sided edema, right-sided edema. But to me, every patient I assess, I always want to know, are they edematous? Now, does that mean that they need to be diuresed at this moment? No. Does this mean that they have venous congestion at this moment? No. Does this mean that we are going to be able to even fix their peripheral edema with diuresis? No. Some patients with advanced right heart failure and pulmonary hypertension, you literally cannot get rid of their peripheral edema. It's not that you wouldn't want to or the patient wouldn't feel better with it, but it's just that their cardiac function doesn't allow you to fully improve their congestion and their interstitial edema. So I think every patient we should be assessing edema for. It's so important. And in our patients with like kind of progressive volume overload in the ICU, this edema that's happening both in our kind of skeletal extremities, but also in our central organs might contribute to some of the organ failure we see related to volume overload and sepsis as well.
Right. Edema of your ankles matters for mobility, which is important. But the edema that we're most concerned about is like edema of the kidney, which is making the kidney not work properly, or edema of the gut, which is making it hard to absorb medications. So, great point. I'll just say one other thing there to piggyback on that, which is that if you're looking at edema only at the ankles in your ICU patient, you're missing a lot of edema because a lot of the edema that ICU patients have is going to be dependent edema. So you got to look at that their backside, not just their ankles.
Another element of the physical exam that often gets a lot of time in the spotlight is the pulmonary exam. Kind of the idea of like rails and crackles and respiratory effort. Can you unpack that a little bit for us, Ross? And like, how much stock do you put into that?
I think it's really important to understand whether a patient has pulmonary edema and pleural effusions. I think that is an important marker of volume overload, although I guess just overload in general, and we want to avoid the term volume overload as much as we can, but elevated left atrial pressure and left-sided congestion. I just am not convinced that for an ICU patient who might have many other reasons to have crackles and rales and wheezes, it's the right test. The test characteristics aren't great. If it's really going to change my management, I would do an X-ray or even if you want to be more sensitive and more specific, an ultrasound. I would say that lung ultrasound is one of the most powerful tools to assess for left-sided congestion and fluid tolerance because patients with bilateral effusions and pulmonary edema very much are on the far side of the Frank-Starling curve, if you will, and potentially being exposed to harms from left-sided venous congestion. So I would reach for a lung ultrasound if it really changed my management in those patients.
I completely agree with you. I think as a pulmonologist, the stethoscope is fairly useless here. I think I could say that without, getting drummed out of, pulmonology society or whatever. But you're absolutely right. I mean, I think the stethoscope still has a few uses. Like, did we intubate the right main stem or not? Is this wheezing person with asthma getting better? But what is their volume status is not one of the things that it can tell you. And I think that's something that's like, the 19th century wants their assessment tool back. Well, let's move on to things that work. So you've mentioned capillary refill a couple of times. Tell us about that.
Capillary refill time is a great non-invasive surrogate of organ perfusion. We don't really care how well perfused somebody's index finger is, the anterior part of their index finger, but it turns out that that's a really good surrogate for what's happening actually at the organs, which we care about. And so the nice things about capillary refill time are if you do a hemodynamic intervention, like start an inotrope or give a fluid bolus, within about even 5 minutes or less, capillary refill time should adapt if that hemodynamic intervention has improved the microcirculation. And this has even led to this concept, which is still like maybe not quite ready for prime time, but I think it's just fascinating, of doing like dynamic perfusion assessments with passive leg raise. So instead of looking at blood pressure and stroke volume in response to a passive leg raise, could you actually assess capillary refill time pre and post passive leg raise? Because if you do a passive leg raise and the capillary refill time, which was abnormal, suddenly normalizes or gets better, all right, we might be improving the microcirculation with a preload challenge. Now, does that mean we should give them fluids? maybe not, because remember, we can increase preload with fluids or with vasopressors, but it suggests that there is coupling still between the macro and microcirculation. And so I think cap refill time is brilliant. I think out of all the microcirculatory surrogates, it's the most accessible, has the best evidence base. There's dozens, if not hundreds of studies showing that abnormal cap refill time is associated with worse outcomes. We're looking at whether or not abnormal cap refill time is associated with congestion and other kind of markers of kind of circulatory problems. And it's also now being supported by randomized controlled trials like Andromeda Shock and Andromeda Shock 2, which is coming out the end of October 2025. The results at European Society of Intensive Care Medicine. I hope that this will continue to support cap refill time as maybe our North Star metric for assessing the microcirculation, because we can all do it at any time.
And it's such a powerful tool. It's just something that is so easy for you to do. Like you were saying before, like, it costs nothing. You're going in to evaluate the patient. You can make that assessment. And then, like you were saying, it's like that gateway into the concept of, are the micro and macro circulatories coupled or not?
Yeah, I think one detail that I'll just add to this is that I believe in Andromeda Shock they use this like microscope slide technique. Do you want to double click on that for us?
Yeah, and I think that this is a good example just on, there needs to be a standardized way to approach it. So what we would do is take a glass slide and apply gentle pressure over the kind of palm of the index finger for 10 seconds until there's mild blanching, and then release it. And then you would measure how many seconds it takes for kind of return to normal color of the skin. The reason why this is important, and I don't carry around a slide with me in the ICU, I don't think many of us do outside of Glenn Hernandez and Eduardo Catan, the investigators on this study. What it means is if you push way too hard, you can delay cap refill time. And if you don't push long enough or hard enough, you can also make it seem falsely low. And so how I typically do it is I gently squeeze the index finger or whatever finger I'm going to be checking the cap refill on until I see blanching, just even for a second. And so I know I'm pushing hard enough. And then I do hold that amount of pressure for 10 seconds and release it to standardize my assessments of cap refill time. And then there is some inter-rater reliability, although that has been studied and it's fairly low. It is worth having a standardized approach that you use, and you're not just kind of pushing on the patient for half a second and seeing, because that's not a standardized, repeatable way of assessing cap refill time.
This is something that I always teach trainees, which is that you really need to get into the habit of assessing this on every single patient you evaluate, so that you standardize the way you perform it, and you can better spot kind of what's the normal range and what's abnormal. And so, for trainees who are listening, I would say just make this part of your assessment. Like, walk in the room, shake the person's hand, introduce yourself, do a little cap refill as you're holding their hand, and just make that part of your routine, because you won't know abnormal, especially subtly abnormal, unless you've seen a whole lot of normal.
Yeah. It's actually the first thing that I assess on every patient that I see.
Me too.
Full stop.
Yeah, me too.
Yeah, that's huge. It's also huge not to just make it routine, but to make the approach consistent and repeatable, which I think is a really elegant point that you bring up. I think just couple other things we can maybe touch on before we peel back the next layer here. I don't check for hepatojugular reflux in the ICU all that often. I don't think it's terribly effective. I think maybe if you're on a cardiac ward and you're dealing with a lot of heart failure patients and you can sort of position them appropriately, then maybe there's a place for it. But I sort of like lump it into the jugular venous assessment as being something that's lower on my list. And certainly if you have any comments on that, I'd love to hear them. But the one I did want to talk about maybe a little bit more was this idea of just eyeballing the blood pressure and eyeballing pulse pressure variation, and what is there to glean from that?
Yeah, there's actually probably more in the pulse pressure than what we initially think of. So pulse pressure is the difference between the systolic and the diastolic blood pressure. When pulse pressure is narrow, and now the thresholds for narrow pulse pressure vary in the literature and probably depend on the patient population. So I'll give some generic or some different options. So often a pulse pressure less than 40 in sepsis is what we talk about. Pulse pressure less than 30 in bleeding patients. A pulse pressure less than 25% of the systolic. All of these have been studied in various trials to predict stroke volume. And so narrow pulse pressure is consistently associated with low stroke volume. And so when I walk in the room and I see a narrow pulse pressure, my first thought is I need to ultrasound this patient if the patient's in shock or unstable, because they probably have low stroke volume and low cardiac output. This is actually being studied by the Andromeda group as Andromeda Pegasus, which is a massive several thousand patient observational study correlating pulse pressure with stroke volume across critically ill patients with septic shock. And so we're going to have much more data on the thresholds, which patient populations that really this holds true for. But I think it's such a valuable data point, to the point that even when I'm in the cardiac surgery ICU and I see a patient post pump who's hypotensive and I see their pressure is like 120 on 30 and their pulse pressure is 90, unless they have aortic insufficiency, that patient for sure has adequate stroke volume, which is really helpful because that patient just needs vasopressors and not fluids, not inotropes. And so for me, it's extremely powerful, particularly in those settings of sepsis and post cardiac surgery where vasoplegia could be easily kind of diagnosed by a super wide pulse pressure if there's no aortic insufficiency.
Yeah, I think those are great points. I almost like the pulse pressure. I think the pulse pressure is almost a more useful measure than like the MAP in many patients, right? Because the MAP is this sort of mythical value that we're trying to bring above some threshold, but it's actually kind of like high versus low pulse pressure shock, which is really diagnostically more useful, I think.
Yeah, that's Nick. That's an awesome point. Great way to look at it. And so, just before we move on, Ross, you mentioned like you see that narrow pulse pressure. You gave us some of the different, ranges depending on the patient subtype. You go by, you ultrasound them, or you do your exam. What specifically are you looking for in these patients to help make a decision? I know we're going to touch on this maybe a little bit later towards the end, but I just feel like we can't skip it now since you brought it up.
Yeah, what I'm really trying to do is understand what's the phenotype of shock. And I try not to use the terms hypovolemic, distributive, cardiogenic, obstructive when I'm talking about shock phenotypes. And the reason why is they intuitively imply a treatment that may or may not be true. So for example, patients with quote hypovolemia or hyperdynamic biventricular function with low filling pressures, they might respond to fluids or pressors. If they're bleeding, they definitely need blood and fluids. And if they're not bleeding, depending on how much vasoplegia they have, they might just need pressors. Patients with distributive shock can have high cardiac output or low cardiac output. Patients with distributive shock can have left ventricular failure, right ventricular failure, left-sided congestion, right-sided congestion, a mix of the above. Patients with cardiogenic shock can have primarily LV dysfunction, RV dysfunction, valvular dysfunction, pulmonary hypertension, all of these different things. And then patients with obstructive shock, it's obstructive from a specific cause, be that a PE, tension pneumothorax, or pericardial effusion. And so really I'm trying to phenotype a patient shock and understand what's their biventricular function, what's their stroke volume, what are their filling pressures, be that high or low, do they have congestion, left-sided or right-sided, and is there something specific I can intervene on? So I try to stay away from the traditional shock phenotypes that we talk about, but that's also because I spend most of my days thinking about shock and phenotyping shock. And so it's something that I think if you really want to go to that next level, we have to move beyond that nomenclature, although probably for trainees and when you're first starting out, using that core approach probably still valid.
I still like that approach. Guilty, but
Yeah.
I don't know. Yeah, but I agree with you. I mean, you gotta be wary of the sort of reflexive diagnosis implies treatment that goes with it.
Nick, I think that's the point. I think that's very elegantly stated because I think like it's not in my mind. It's like that. I totally hear how the paradigm may be fraught with peril if you are superficial about it. But I think if you use the paradigm in the context of everything we've been discussing so far, and we're like, okay, cool. I think this is the kind of shock that's going on, but that does not necessitate a particular treatment strategy. It necessitates a careful examination of the patient. I think that probably course corrects you appropriately.
I think it does. And I totally agree with you. You can approach shock and terms are just terms and labels are just labels. I think in this particular scenario, though, there can be some problems. And the biggest thing I encounter is the hypovolemic. Because if I say a patient has hypovolemic shock, what is the treatment? It's volume, right? It's in the name, hypovolemic. You replace the volume. And so it's hard to conceptualize.
It's almost malpractice to not give volume for hypovolemia.
Exactly. Yet if you said that this patient actually has low mean systemic filling pressure and impaired venous return as a result of low mean systemic filling pressure, which is making a patient look hypovolemic, and I have big kind of bunny ear quotes in the air as I'm saying this, then that allows you to have the cognitive flexibility to think, all right, well, the treatment may be fluids, but it may also be pressors. Another example is cardiogenic shock. If I said, what's the treatment of cardiogenic shock? Inotropes is what everyone is thinking when we first say it. Yet I would argue if you have a patient with cardiogenic shock with really, really high afterload, you could just treat that with a vasodilator instead.
Right.
If you have a patient with a valvular problem, the issue isn't about inotropy at all. It's about fixing the valve. And so we just have to be a little bit careful about how terminology influences our thinking about the treatment. Hypervolemia and hypovolemia being highly associated with diuresis and giving fluids, when really that we know that our hemodynamic system is so much more complex than that.
Awesome. Wow. Yeah. Really great discussion. I think that's another huge point for our listeners to take away is like, in the same sense that the micro and the macro circulation can be, disconnected, same kind of concept between like labeling shock and then the intervention. Just because you're saying it's hypovolemic shock, there are many ways you can approach that. And one size does not fit all. So, a great list of tools we've already talked about, many of which are truly right at our fingertips or right at your patient's fingertips. I know that ultrasounds come up a few times. We're going to talk about that at the end of our discussion, really to make sure that it gets appropriate focus. But many of our patients in the ICU, Ross, already have some other tools that are sort of on them, whether it be arterial line or what have you. And they're pretty easy to just kind of like take a look at, make some decisions. They don't require all the time of an ultrasound. What do you make of some of those tools? Things like your arterial line, pulse pressure variation, stroke volume variation, central venous pressure off your central line. How do they fit into your approach to the critically ill patient?
Whenever we look at a hemodynamic assessment tool, we have to always preface it by what are we assessing and why. And so most of the tools that we're going to talk about, pulse pressure variation, CVPs, esophageal Doppler, pulse contour analysis, are all designed to predict fluid responsiveness or preload responsiveness. Will a patient increase their cardiac output in response to a fluid bolus? And so let's frame the discussion surrounding fluid responsiveness. And I'll just start off with a caveat that most patients I don't assess for fluid responsiveness, because if I think that the patient has microcirculatory dysfunction, they are fluid tolerant, and they might have a low stroke volume, I'll probably just try giving them fluids and then assessing their cardiac output after to see whether or not there was some sort of hemodynamic response, or just reassess their microcirculation after to see whether or not there was some sort of microcirculatory response. With that said, if I am going to look at the art line, high pulse pressure variation is associated with preload responsiveness. There's some caveats like any tool, but preload responsiveness, again, doesn't mean fluid, because these patients actually distributive shock with low vascular resistance are also preload responsive and can also have high amounts of pulse pressure variation. You can also see high pulse pressure variation in things like tamponade, in things like RV failure as well, dynamic LVOT obstruction. So when I see very, very high pulse pressure variation for a patient in the ICU and they're in shock, I immediately think, all right, I need to figure out why there's a high amount of pulse pressure variation here and what I'm going to do about it.
Let's pause there because I think there's a lot of important physiology that you hit on there. And I think maybe we should just step back and define a little bit for people, because I think a lot of people view like pulse pressure variation as just sort of this wizardry. Like, how does that work? And, I always tell people like, it's really simple. Your chest stores two different organ systems, right? It stores your lungs and your heart, and those two interact with each other. So that during the respiratory cycle, if you're breathing spontaneously, the pressure gets more negative. If you're on a ventilator, the pressure gets more positive. And that change in pulmonary pressures, that change in pressure in the chest, will affect the filling pressures in the heart. And that's the essence of this technique. I think the thing that people often sort of get stuck on are like some of the nuances of it. Like what are we measuring exactly on the monitor versus if the monitor does it for you? What threshold are we using? But I think that the concept is the really important thing, which is that in somebody who has low filling pressures, a variation in chest pressure will cause the cardiac output to fall, which will cause the pulse pressure to fall. Do you want to add anything to my simplistic explanation there?
No, I think that's a beautiful explanation. I think the only thing I would add to, and which is why sometimes pulse pressure variation can lead you astray, is that also patients with high filling pressures from RV failure can also have the exact same physiology. It's reversed, but it can look the same on your arterial line. And that's why it's when I see it, I don't just reflexively treat with fluids or vasopressors or anything. I really want to understand why. And a good example is patients with dynamic left ventricular outflow tract obstruction have some of the greatest pulse pressure variations you will ever see, like 50 or 60 points, these insane values. And it's actually because with respiration, they're like completely obstructing their LVOT. probably a topic for a different crit care time, but very, very interesting. And one of the reasons why we can't just rely on the number by itself, we have to understand the anatomy and the physiology.
Furthermore, Nick, to your point from earlier, like the patients that are breathing spontaneously and having variations in their respirations, like that's kind of the population where this isn't really designed for as per se. I think the kind of group that this is quote unquote validated for are folks that are mechanically ventilated with controlled settings, essentially those that are on neuromuscular blockade, to try to eliminate some of that variation. But a lot of our patients in the ICU aren't necessarily fitting that mold. So
This
it's like,
is like Ross's point about the standardized approach to cap
exactly.
refill. If you're going to use pulse pressure variation, it's best to use it in a standardized way. So just
Right.
understand the limitations, that it's going to be dependent on rhythm. It's going to be dependent on the ventilator volumes delivered. It's going to be dependent on, or rather, it's going to be dependent on not having patient effort, I should say. Anyway, all of this is in the show notes. I'll just say we have a summary of all of this. So we don't have to go through all of the criteria here, but I think it's really important to understand the concept.
Absolutely. We'll make sure that those show notes have all this information for you guys to reference. I know you guys, look at that stuff, and we put a lot of effort into it. So happy to do that.
86% of you say that's really important in our poll.
Yes. Yeah, that's right. 86%. We have mentioned CVP a few times. I want to talk about that with you, Ross, but I'm also, apologies, I'm very, very dense. And so I want to make sure that there's maybe possibly one other listener out there that's as dense as I am. I really want to like hold your feet to the fire and say, when you talk about like the prototypical patient for whom their macrocirculation and their microcirculation are uncoupled. So you walk into the room, you see something that's worrisome, you do your assessment. What would be like the perfect example of that patient?
That's a great question. It's really hard, actually. So, when you first assess a patient who has clear microcirculatory abnormalities, you don't know whether or not they're coupled or not. In fact, determining that somebody is hemodynamically uncoupled, or I'd say a better term is probably incoherent, is the term typically we use, hemodynamic incoherence, where changes to the macrocirculation will not improve the microcirculation. That's really a diagnosis of exclusion. And I go through a systematic approach assessing different parts of their circulation to identify abnormalities. And only after we've concluded that we've tried to optimize those all and we are still unable to improve their microcirculation, would I deem somebody hemodynamically incoherent. A good example of that is um, early on in septic shock, most patients are hemodynamically coherent, but as septic shock progresses, many patients become hemodynamically incoherent. And we think that there's a few different mechanisms for this. Some of them are just related to the underlying pathophysiology of sepsis with endothelial dysfunction, microthrombi, all of that. But other patients, it might be the edema and the congestion that they experience, which actually causes the capillary beds to shut down. And so that's one of the potential mechanisms by which volume overload is harmful for patients. And so later on, when you have a patient who's overloaded in the ICU, they're modeled, they have horrible cap refill time. You've tried inotropes, you've tried Lasix, you've tried fluid removal, you've tried vasopressor challenges, you've tried reducing their congestion, you've tried increasing their congestion by giving them more fluids, you've tried reducing their PA pressures, you've tried everything. And they are still just in this dense shock and microcirculatory dysfunction. Those are the patients you might deem hemodynamically incoherent. And the treatment strategies for hemodynamically incoherent patients are limited. There's some thought that perhaps removing excess interstitial edema may help these patients. There's interest in things like localized vasodilators, et cetera, et cetera. All of this is very experimental at this time, but I try to prevent people from becoming hemodynamically incoherent as much as possible. And the biggest modifiable risk factor we think there is probably volume overload.
Which is why we're having this conversation in the first place, right? Because volume overload, bad. So being thoughtful about fluids, good. I'm just going to, as a quick note for listeners, that incoherence is coherent in like the physics sense. It's like two waves interfering with each other or constructively adding to one another. It's not like coherence, like the crazy person writing on the wall and like, rambling incoherently.
Yes. Yeah, good point. And so Ross, just one other question to follow up on that before we get to the CVP, because I think a lot of what we're talking about does kind of connect to the central venous pressure. If you go into the room and let's say you see a patient who is, their MAP is less than you'd like it to be, recognizing that MAP is, of course, a flawed metric, but they got a low MAP. they've got a high pulse pressure variation, let's say. You go in there, you do, let's say, a passive leg raise, and we'll give them an arterial line. You go in there, you do a passive leg raise. The blood pressure gets better, let's say, but their capillary refill, which you checked before you did anything else, doesn't change at all. So would that, I mean, am I like oversimplifying that, or is that like is that something that would give you pause and you'd need to investigate further? I'm just trying to, like, I know I was like railing on being reductionist, but I'm trying to make it somewhat simple just from a conceptual standpoint.
Yeah, and maybe a caveat that this is probably on the bleeding edge of what the evidence base is. So opinion and kind of buyer beware here. So
For sure.
the first thing I'd say is when I do a passive leg raise, I never look at blood pressure as a marker of successful passive leg raise. Imagine you're in bed at night, you're having a wonderful sleep, and some stranger comes into your room and grabs your legs and shoves them over the head in the middle of your night. I guarantee you your blood pressure is going to go up. It's pulling on your Foley catheter. It's causing pain. You have bed sores. It is it's a very big experience for patients in the ICU. We wake them from their slumber doing it. So of course their blood pressure is going to get better. So I think the first thing I'd say about passive leg raise is we're not looking at blood pressure. You have to assess some sort of marker of stroke volume and cardiac output. But even that could be limited as well by saying that, yeah, of course, when you stimulate somebody and scare the crap out of them, they're going to have a catecholamine output and they might increase their cardiac output. So I would want to assess, so when I do a passive leg raise, the things that I typically look for if I am doing one are going to be things like serial VTI measurements from kind of on ultrasound and looking at actual stroke volume and cardiac output. Or if you have a SWAN, maybe thermodilution, for example. So that'd be my first comment. Would I say that a passive leg raise is totally, a fluid bolus is not justified if I saw a cardiac output response, but the cap refill didn't change? I don't think the evidence is quite strong enough yet. There is certainly an interest in doing these dynamic tests of hemodynamic coherence, but I don't think it's strong enough that I would necessarily, if I had a patient with microcirculatory dysfunction, they were fluid tolerant, and now I've deemed that they're fluid responsive, I would probably give them the fluid bolus or vasopressor challenge to increase their preload and assess the cap refill after that, as opposed to just relying on the passive leg raise. But this is something that's actively being studied by multiple groups.
Okay, so my attempts at making it simple have failed, but that's in keeping with kind of the content here, which I think at the end of the day, it's complicated. It's not that easy to kind of just sort through in a couple seconds. So trying to bring things back to the topic at hand, we've kind of danced around this a little bit, but the idea of the central venous pressure via the central line, which is clearly the be all and end all, right, Ross?
Yeah. I mean, if you ask the central venous pressure the right question, it might be helpful. But if you ask it like the IVC or like any tool, the wrong question is not. So if you ask the central venous pressure or the IVC, if we're going to just say that IVC is really just a surrogate of kind of right atrial pressure, or sonographic reflection of right atrial pressure, I should say. If you ask it where you should go for vacation or what you should have for dinner, it's not going to give you a very good answer. If you ask whether or not the patient's fluid responsive and is going to increase their cardiac output in response to fluids, it doesn't really work. But if you ask, hey, is this patient potentially going to be harmed by IV fluids, aka is this patient fluid tolerant, it might start telling you some things. So we know that patients with elevated central venous pressure have worse acute kidney injury. We know that it's an independent risk factor for renal failure, in fact, for critically ill patients. And so I think there may be some role when you're looking at a patient with congestion, not only at the number, but also the waveform associated with it as a surrogate of RV pathology. But I wouldn't use it to justify giving more fluids because, again, patients with low CVP could be fluid responsive or unresponsive. They could be fluid tolerant or intolerant, and they could have normal or abnormal microcirculation.
Great point. Yeah, I think we've talked about this before on the podcast about how the unfortunate legacy of Manny Rivers and sepsis was this highly protocolized approach to using CVP, which sort of led people to think that CVP was a surrogate for should I give fluid, which it's not. And then there was this sort of reaction formation, the sort of ICU nihilists were like, oh, never check it for anything. It's useless. And neither one of those things is true. It's useful, but it's useful not in the way it was used, just as you explained.
So In an effort to get kind of to ultrasound, because I know we want to talk about that and give that its due diligence. There are a lot of proprietary tools out there, Ross, that you can use. Things like the Flow Track or the Vigil.AO for pulse contour analysis. There's esophageal Doppler monitoring. There's the non-invasive kind of Cheetah devices that do bioreactance, bioimpedance. Can you sort of just give us the 10,000-foot overview on those tools and where they might fit in your practice or where they should fit in general practice?
Yeah, I think all of these tools, for the most part, are best at assessing for fluid responsiveness and stroke volume. And so having a way to assess for stroke volume and fluid responsiveness is important. If that's ultrasound at your shop or in your practice, great. If it's one of these tools, great as well. The important point for all of these is that our job as intensivists or as clinicians in general is not to eliminate fluid responsiveness. We're not trying to find fluid responsive patients and give them fluids until they're fluid unresponsive, because fluid responsiveness is a normal
That's called
physiologic state.
drowning, by the way, if you just do that
It
to
is. It
everybody.
is.
Yeah.
And so all of us right now are fluid responsive, but none of us need fluids. And so I think in the select scenarios where you're really balancing the risks and benefits of fluid, they have some markers of like microcirculatory dysfunction. They have some markers that they might not be fluid tolerant, but they also have some markers that they might need fluid and be fluid responsive. When you're really trying to balance those things, having any tool like this, be that Echo or any of the tools that you mentioned, is valuable to help sort those patients out. However, I would propose that that's probably the minority of patients. The patient population that I see this the most, where I really struggle with this, is in the cardiac surgery ICU after a big pump, where you have a patient with a poor heart and then they're bleeding, or they might be having some degree of true hypovolemia, hemorrhagic shock. And you're really trying to decide how far do you go. As you're giving them blood and the pressure's not good and you're on inotropes and you're giving them blood and you're really trying to figure out where are we in this truly mixed picture of shock where there's hemorrhagic shock and vasoplegic shock and also cardiac dysfunction. In those patients, having some objective way before you give them another unit of blood, before you give them another half liter of crystalloid to assess whether they're going to respond to it, that is really, really useful because those patients are likely fluid intolerant and giving them too much fluid can harm them, but also they are also potentially very fluid avid and they need fluid as part of their resuscitation. So in that patient population, having a really good tool, for us, it's often swans with thermodilution, I find
Right.
really, really valuable.
And that's exactly what I was going to mention is like, okay, so I've talked about some of these proprietary kind of newer tools, but what about the good old fashioned swan? And in your patients that you're talking about, they're often going to come out with the swan in place anyway. So I'm assuming that you're kind of using that as the quote unquote gold standard or historical kind of standard to make some of these decisions in these trickier fringe cases.
I would say yes, with also trying to get some echo data, be that transthoracic or transesophageal, because the great thing about SWAN is you get dynamic real-time data, you can assess physiology, but there's always the physiologic and then anatomic correlation. And those two together, particularly in a complex shock patient where they might have regional tamponade, hematomas, all that stuff, I think that's really where the money is. So I love seeing both anatomic and physiologic data. And that's what we discussed on the Resus TEE podcast that we did a few months ago. It was really how having those together is just peanut butter and jam.
Exactly. The way I think about these tools, as somebody who uses these tools a lot in my shop, is I think of them as sort of a staged assessment. That like these are things that skilled bedside nurses can use as part of their assessment, but that doesn't mean I don't have to come and do my own assessment with ultrasound. That it's great. We use NICOM a lot. We use pulse contour analysis. We use swans with thermodilution. Like we use all these all the time. Like almost every patient has at least one of these. But it doesn't mean that ultrasound isn't crucial because it's going to give you that and more. The value of these, in my opinion, is that they're continuous, and this can be going on in 10 different rooms at once, whereas I can only be in one room at once.
And just remember too, we talked about thermodilution. There's also FIC that you can use. Thermodilution. The one issue you can run into is that if the patient has tricuspid regurgitation, it can kind of throw off your calculus. So my practice, I usually check them both, and I often will follow the FIC. But yeah, so cool. I think great discussion. Now, sort of, I fear that we've buried the lead for a while, but it is what it is. Let's get to the ultrasound stuff. Let's talk ultrasound, and really, I think, Ross, the floor is yours to lead us on your journey through, okay, I've got the tool in hand. I'm ready to assess this patient. How do you attack that patient in the most kind of not actually attack them, but maybe I should say, how do you approach that patient to get the data that you need to save their life?
We've kind of throughout this discussion emphasized the fact that the terms volume status are probably unhelpful and not specific. And so I think we should be really specific about what ultrasound is useful for. Ultrasound may have some role in determining whether a patient's fluid responsive or whether or not they will increase their cardiac output. Specifically, if you can measure a left ventricular outflow tract VTI, which is a surrogate of stroke volume, and repeat that pre and post passive leg raise or pre and post bolus, and you see an increase there, that's a great way of telling whether a patient's fluid responsive, and I love it. I would say that every other indication of ultrasound for, and I again air quotes here, volume status, but really kind of like hemodynamic assessment, probably supports that ultrasound is very good at assessing for fluid tolerance, specifically assessing for things like fluid where it shouldn't be, like pleural effusions or ascites, and then congestion, which could be left-sided or right-sided. So for left-sided congestion, things like lung ultrasound to assess for B lines, there's great accuracy in detecting elevated left atrial pressure and implying that perhaps the patient's congested on the left side. But just like there's two sides to the heart that pump blood forward, there's two sides of the heart that pump blood or that can backflow. And so when blood backflows on the left side, we get pulmonary edema. And when blood backflows on the right side, we get systemic organ congestion or venous congestion. And really, Doppler ultrasound, and we're going to talk about VEXUS, is the ideal tool to assess for organ level congestion from right-sided systemic congestion. And one of the things I often get asked or people say is, well, there's not much evidence supporting VEXUS. I totally agree. You know what? The actual scoring systems which support the using Doppler at the organ level, those are relatively new concepts, and the thresholds we're still studying. We're studying this in septic shock ourselves. But the concept of right-sided congestion causing organ failure has actually been around for almost 100 years. In 1931 even, there was a study where researchers put a balloon into the renal vein of dogs and inflated it to increase the venous pressure. And they showed a reduction in GFR that was from inflating the balloon that was the same as dropping the MAP by 10 points. So whether or not you increased the CVP I shouldn't say CVP, the renal venous pressure by 10 points or decrease the MAP by 10 points, there was the same impact on GFR. And this has been shown in humans with intra-abdominal pressure studies all the way back into the 1940s. So we've known for close to 100 years that elevated venous pressure can cause organ failure at the kidneys. We also know that it can cause bowel edema, which gives rise to this concept of cardiointestinal syndrome. There's been evidence and studies showing that in post-cardiac surgical patients, cerebral edema is associated with venous congestion and vice versa, and you get cerebral desaturations from high venous pressures. That's something we're looking at in septic shock, looking at delirium rates and neurocognitive outcomes for ICU survivors, depending on whether or not they had venous congestion during their ICU stay. And so all that to say that high right-sided pressure causing flow abnormalities in the organs we care about is bad. That is almost like a definitive truth in medicine. Just how a MAP of 30 is bad for patients and a cardiac output of 1 is bad for patients, severe venous congestion is bad for patients. The question is,
right. You don't need an RCT to prove that, right?
Exactly.
Like that's just physiology. Like that your perfusion pressure is your MAP minus your CVP in this case. Like that's just like an immutable law of physiology. That's not something you need to like randomize patients to ascertain.
Exactly. The question though is, how should we assess for this congestion and what thresholds should we assess for congestion? I mentioned that CVP is associated with organ failure at a population level, particularly acute kidney injury when it goes really, really high. But the problem is for an individual patient in front of us, an elevated CVP may not adequately predict acute kidney injury. And there's a bunch of studies showing this. And so this is where the idea of using Doppler ultrasound or the VEXUS score came from, is instead of trying to extrapolate a pressure in the heart down to the kidneys, where there's a lot of things that can influence how that pressure is being transmitted retrograde, why don't we just measure the flow at the organ that we care about? And that's what Doppler allows us to do. And so the VEXUS score, Dr. Deneau and Dr. William Beaubien-Souligny in Montreal, they came up with this comprehensive scoring system assessing the IVC, the hepatic vein, the portal vein, and the intrarenal venous Doppler, and essentially saying, is it normal, mildly abnormal, or severely abnormal? And the more abnormalities, the higher your score is, from 0 to 3, with 0 and 1 being relatively normal and 2 and 3 representing moderate and severe congestion. And it turns out that using the VEXUS score had better predictive accuracy to predict acute kidney injury than any of the kind of individual Dopplers by themselves or central venous pressure. And now this has been studied for dozens now, studies across critically ill patients, showing that elevated VEXUS is consistently associated with renal failure. It may be associated with increased mortality, which is something that we've shown in septic shock. It likely is associated with increased need for renal replacement therapy. And so it's bad. The question, though, now becomes, what do you do when you detect congestion? Because congestion is not volume overload. And this is why the term volume status is so problematic.
Well, two things I was going to say. One is, and just to get technical, all of this is with pulse wave Doppler that we're talking about.
Correct.
Perfect. And then I'm starting the term like volume misappropriation is coming to mind, like as opposed to like just being more being simpler about it. I don't know. It's like the volume's there, it's just not where it's supposed to be, and it's causing problems.
And it's really coming down to the flow and the retrograde flow with the volume that, in my mind,
Right.
especially when we're talking about congestion, is really the main problem.
Okay, cool. So yeah, what do we do now that we found it?
Yeah. And so when I first talk about venous congestion on the right side of people, sometimes people are like, oh, this is really confusing. But we talk about left side of venous congestion from the first day of medical school. And let's think about pulmonary edema. And so it's something we're all very, very familiar with. To develop pulmonary edema, you have a substrate in the heart that means that you could develop pulmonary edema. That could be systolic LV dysfunction, valvular problems, aortic stenosis, mitral stenosis, mitral regurg, and then also like diastolic dysfunction as well. So you have some sort of cardiac problem, and then you overlay that with filling pressure problems. So if you give somebody 5 liters of fluid and they have an EF of 10%, there's a good chance they're going to go into pulmonary edema because the loading conditions combined with their cardiac function leads to this outcome of left-sided congestion. Well, it turns out that that's the same thing on the right side with right-sided systemic venous congestion. Patients will have a substrate for developing venous congestion. That could be RV systolic or diastolic dysfunction, pulmonary hypertension, tricuspid regurg, pericardial effusions, elevated intrathoracic pressure. Any of those reasons that blood flow into the heart would be impaired. And when you combine that with kind of loading conditions like volume overload or giving somebody excessive IV fluids, or even just acute RV failure, patients then manifest backflow from the right side and right-sided venous congestion. And so it's really the interplay between the two which determines the severity of congestion. And that's why we see that RV failure is highly associated with venous congestion. And so the treatment for venous congestion on the right side might not just be diuresis, it might actually be an inotrope to improve RV function. It might be a pulmonary vasodilator in the context of elevated RV afterload. It could be a tricuspid clip or tricuspid valve repair in the case of chronic tricuspid regurgitation. We're actually starting an RCT looking at, and Dr. Basmaji at Western and I, looking at venous congestion guided resuscitation in septic shock. And the treatment for patients with severe congestion is not simply to remove fluid or diurese them, it's to optimize the cardiac function and the interplay between the heart and congestion. And that could be inotropes, inodilators, ventilator studies to optimize PEEP and avoid overdistension, all these things that can contribute to organ dysfunction.
So what I'm hearing is the classic paradigm of like congestion is a volume problem is kind of like hyponatremia is a sodium problem. Like that's really not the case. We're missing the forest for the trees when we focus on the fluid itself and not on how it got there. So, if there's RV dysfunction, if there's right-sided valvular disease, and we're sort of like turning a blind eye to that and just focusing on giving more and more Lasix, we could really be like totally missing the boat.
Exactly. And that doesn't mean that the congestion itself is just a bystander in this process. And I want to emphasize that. We would never say that a patient's pulmonary edema isn't the problem, it's just their LV failure. No, of course
Right.
not. The pulmonary edema is going to cause them to go into respiratory distress and become hypoxic and need to go on BiPAP or be intubated. Similarly, the congestion that's caused from RV failure is probably part of the causal pathway in which these patients develop organ failure and die. Think about chronic pulmonary hypertension patients that have horrible appetite because they have early satiety and nausea and abdominal distension. This is systemic venous congestion causing bowel edema, making them not eat. That's a problem. They become malnourished, and potentially improving congestion in those patients would actually improve their ability to kind of live longer and stay well nutrished and grow strong and recover, for example. And so I think it's really hard figuring out exactly what is the role of venous congestion versus the cause of venous congestion and the treatment. And that is still the area that we're really, really trying to study through various studies that we have ongoing and many investigators worldwide are looking at.
And sometimes it's even more complicated than that. Not that this isn't complicated enough, but just like this concept that like, if your renal perfusion pressure is a consequence of your cardiac output determining your MAP and your filling pressure, we'll say CVP, right? Well, as your kidneys fail and you retain volume, your CVP rises, and then that perfusion pressure gets worse. So it becomes not only does the symptom, become a problem in its own right, but it causes the pathology to worsen.
I tried to make a direct acyclic graph for my master's looking specifically at the role of venous congestion in this causal pathway, and it became very, very complicated. So I omitted it from my final thesis because I couldn't quite make it work. There was so many variables. So it's definitely super complicated, and we're only starting to understand it. But just how low MAP or low cardiac output causes organ failure, so does venous congestion. And how we detect that, how we treat that, that can be really hard, and balancing the risks and benefits of treating that. But I think that when we kind of maybe zoom out here and think about kind of this broader discussion about volume status, or why maybe we shouldn't use volume status as a term, we need to consider both forward flow in our hemodynamic interventions that we do to improve perfusion, and also backflow. And that's this congestion piece, which is probably the missing side of the circulation. And we've two sides of the circulation, and there's no reason to think that arterial circulation is way more important than venous circulation, when we know that high venous pressure causes organ failure and can cause a lot of systemic problems.
Great. I'm imagining, by the way, that this this figure with venous congestion is like that meme with like all the string on the board and all the newspaper clippings and stuff. It's just like everything ties together here. It's the source of all evils, like any good conspiracy theory.
All right, guys. So we covered a tremendous amount of content with Dr. Ross Prager here. We discussed how the idea of volume status is maybe not the right approach, but rather the importance of things like a volume assessment and concepts like volume responsiveness, fluid tolerance, and the ideas of macro versus microcirculatory dysfunction, and how there can be this discordance between the macrocirculation and the microcirculation, this uncoupling, if you will. We then discussed numerous exam findings, tools available in many ICUs around the country and around the world. We talked, of course, about the power of ultrasound and then utilizing that VEXUS scan when it comes to assessing for congestion. And then finally, we did include some cases to try to illustrate the points that we discussed today.
I always tell our listeners, go to www.criticalcaretime.com for the show notes. In this episode in particular, there's going to be a lot of great stuff there. There's going to be some infographics related to tools for fluid responsiveness and fluid tolerance. We'll have some stuff on VEXUS. We will have links to the prior episodes that we mentioned. We'll have links to the studies that Ross mentioned, like Andromeda Shock 1 and soon to be the sequel. While you're there, you can subscribe to our mailing list. You can leave us a comment. Yeah. Part of the show where we like to say thanks. Thanks to our listeners who have done that, who have left us comments. You keep us motivated and inspire us with good ideas. We also appreciate everybody who's left us reviews and all the other shout outs on social media that are, warm our hearts. Anyway, I would also say a big thanks to our guest, Ross. Thanks so much for coming and dealing with us a second time. It's so good to have you.
Thanks so much for having me, and just such a great discussion, and I love hanging out with you guys.
Oh, thanks. And Ross, before we continue, I know we talked about some of your achievements and things that you're working on. Anything else you'd like to plug before we sign off?
No, just if you're interested in kind of diving deeper into hemodynamics, like hcprounds.com is kind of our platform where we have a bunch of our previous recordings on YouTube where we dive pretty deep into some of these concepts. I'd say check that out, but I'm sure
check out this guy's website, follow him on Twitter or X, Ross_Prager. He's got amazing tutorials or Xtorials or whatever.
Oh yeah. I love reading
lots
those.
of great learning there. Yeah. Give this
it.
guy a follow.
Thanks, guys.
So yes, thanks again, Ross, and to our audience, we really do hope you guys enjoyed the show. We put a lot of our blood, sweat, and tears into it, and some of our volume, if you will. Please be sure to subscribe, give us a like, leave us one of those 5-star ratings if you have it in your heart to do so on your favorite podcast app. This really does help us tremendously expand our audience and reach other folks. And in the same vein, also no pun intended, please, if you have anyone out there that you know that's not listening to us, hey, turn them onto the show because we'd love to have them as a listener.
Yep. We love hearing from you. Keep hitting us up with complaints at cyrus@criticalcaretime.com, or, praise. You can reach us at Nick M. Mark at Twitter, at AskinsRazor, at Critical Care Time. We're also on Instagram, Threads, YouTube, Blue Sky, every platform you can imagine.
Before we go, we'd like to thank the incredible members of our team. We've already thanked, I think, our audience, but we do have to thank the folks over at Podcast in Australia for making this show possible. We also want to thank the venerable Kurt Belknap for the awesome theme music that you guys are listening to. And then finally, the podcast is for educational entertainment purposes only, shouldn't be used in lieu of seeking medical advice, of course. Thanks for listening. I'm sorry.
ChatGPT is where you should seek medical advice. Yeah.
Yes, absolutely.
See you next time, folks.